Welcome to the ITS Friday seminar. Okay, let's start. Welcome to the ITS Friday seminar. And today we're very pleased to have Professor Linda Hill. She's from UCSD, and she's a real MD. So we're probably the first time in this seminar we have a medical doctor to give a talk. So she has a long list of accomplishments, and she's with the Department of Family Medicine and Public Health at UCSD, and she's the director of the UCSD SDSU, that's San Diego State, the General Preventive Medicine Residency and Senior Staff Physician at San Diego Family Care. She's the director of the UCSD Training, Research, Education for Driving Safety, and the Center for Human and Urban Mobility, and also direct the AAA Foundation for Traffic Safety Long Road Study at the San Diego site. Her driving safety work is really enhanced by the collaborative effort with colleagues at UCSD with expertise in robotics, computer science, neuroscience, and engineering. I met Linda 2 years ago at the Irvine Symposium, and I was fascinated by her work. And immediately I thought we should invite her to come here to give a talk, and here she is. Welcome.
Thanks very much. When I was thinking about what to talk to you all about today, I'll tell you what I didn't choose, and then you can think about whether you want to hear about that, and I will come back. So at UCSD, we are funded by AAA Foundation for Traffic Safety, and we have the largest older driver cohort for collecting prospective data on older drivers. We have their cars instrumented with a GPS accelerometer. We've now moved to a phone app to do that. And we're collecting 5 years of data on older drivers so that we can better understand them. We also have a simulator lab, and we've been doing work to try to understand the distracted brain, which we'll talk a little bit about because I'm going to show you some of the work that we're doing to try to influence distracted driving. So what I did decide to talk to you about was the work that we're doing that's more public health in the area of behavior change. And the concept is that 95% of crashes are due to human behaviors, and those behaviors are modifiable. We don't use the word accident anymore, as you know, because it kind of implies that that wasn't a modifiable or predictable behavior that caused it. But we, injuries behave very much like other public health diseases. So we decided to approach them that way. And one of the things that we've done, I think that's a little bit unusual with our public health work, is that we've partnered with law enforcement. This was not something that I've done. As you kindly said in the introduction, I actually see patients half the time. I'm a preventive medicine and public health physician in a nonprofit community health center. I've spent my entire career working with people who don't have insurance. And I'm also involved in migrant, asylum seeker, and displaced person health. So that none of that had brought me in contact, or personally in contact with law enforcement. So the concept of being able to use them for public health was something that we came into about 15 years ago. And the way that we've been using them is so that law enforcement can be our behavior change agents. I mean, there's 40 million people in California. It's very large. We're a really small group. And it would be impossible for us to get our message of public health, public safety out in terms of driving safety. So we came up with this idea that we would harness the what they call public information officers, the PIOs. And it was California Highway Patrol who agreed to partner with us. So our model is that we think about what we want to impact, let's say distracted driving, and we'll do what you would do if you were writing a term paper. you'd look at the scientific foundation of it, you do as much research as you could, you pick up some pilot studies, and then base it on health promotion theories. By the way, if you have any questions, just raise your hand. I can answer them as we go ahead. So then we would design some kind of intervention that's usually in the form of curriculum that I'm going to show you, but not completely in the form of in-person curriculum, and then start into sort of a circle of quality improvement, train our PIOs, get them to deliver it, evaluate it, and so on. So CHP has actually embraced this because they're generally not experts in curriculum. They're not experts in, psychology and behavior change. They're law enforcement officers who go on to become public information officers. They were very happy to have this partnership. As a result, we've created 6 curriculum that are for the general public. And I'm going to show you examples just so you can see the kind of thing that we've done, and then give you some very brief examples of the kind of evaluation that we've done. And I'll talk about that in a bit. When we thought about what health promotion theory did we want to kind of model this driving behaviors on, we were attracted to the social ecological model, and especially in the area of, let's say, distracted driving. So the social ecological model says that if you're trying to get somebody to change their behavior, often just talking to them about how that behavior affects them as an individual doesn't work. I mean, take smoking. I've spent a lot of time in the exam room in my office, in my clinic, trying to get people to quit smoking. And sometimes they just say, well, for me, the pleasure outweighs the risks. But when you start talking to people about you're modeling this behavior for your kids, you're providing second and third-hand smoke even if you don't smoke in front of them, there's still third-hand smoke. You're also increasing the healthcare costs of your work. So all of this, you're trying to say to people, okay, this is how it affects you as an individual, but there's also your interpersonal, your work site, and the community. I mean, one thing about smoking, it's one of these things where, short-term pleasure, short-term addiction. Not that I know, I've actually never put a cigarette to my lips, but the consequences are long-term. And so this is very similar to what happens with our phones, a kind of addiction that we have. And it's an addiction because if one of you gets a text while I'm talking, even if I've managed to capture your interest, I know you're going to look at it. That means it's completely capture us, and all those pings and things are affecting our endorphin rush and so on. So the first example of a behavior change that I'm going to show you is what we call Just Drive, and this was our curriculum for distracted driving. The curriculum goes through what some of the reasons are that distracted driving is so dangerous. So I'll just give you some examples. So it would say, when you're looking through your windshield, your eyes are unconsciously scanning the windshield in front of you, looking for things in the periphery. But when you're distracted, that actually goes down by 50%. And we know this because we've put eye trackers in cars, and we put eye trackers in simulators. And I just did that experiment this year. We had some funding from the ITS that was given to us to study that we just finished in September, looking at what happens to eyes in a simulator during distraction. And it completely narrows the focus either to the phone or straight ahead, and all the stuff that's happening in the periphery gets missed. The other thing we show people is you can't really multitask. So here's your brain, you have to imagine somebody got the IRB to do this experiment. They've got somebody lying in an MRI with a simulator over them and a steering wheel. Okay, and some cell phone in their ear. And when they started talking on the phone, the language part of the brain lit up and the visual spatial part lost a third of its function. So we're trying to get...
You don't want to put people through what I put people through. It's not worth it. I tell my story and I want them to look at me and be able to say, I do not want to be, I don't want to do what he did. I don't want to cause the pain that he's caused. I was 19 years old. On my way to work, I made a choice to text and drive. I think back now and I mean, what was I thinking? It is clearly dangerous, clearly obvious, and it makes no sense to me that I could think like that. And you know, now I have to live every day in regret because I thought I could do it. And I hate myself every day for it. I was less than 5 minutes away from work. Could whatever I was texting waited 5 minutes? Yeah, absolutely.
So we don't want to spend our entire 45 minutes that we have with our audience scaring them because we don't think that works. But we also want to show that being either a victim or a perpetrator is not a very good place to be. And so we also show it from the victim's point of view. We've also tried in our talks to interject humor. And you may be a little doubtful about this, but the PIOs that we employ to give our talks, they have been very good at telling stories about the stupid things that people do when they're distracted driving. And what we hope is that people then go home at night and talk to their families, or they talk to their employees. One of the ways that we've been able to get to the public, the distracted public, is by going through employers and saying, if you let us have your employers for an hour, at the end of that hour, we hope they'll be more informed about distracted driving. You'll have less liability. And by the way, we'll work with you also to make sure that your policies are the way that they should be. We've done a number of surveys asking people about distracted driving. One of the things people say is, well, if my boss calls, I have to answer the phone. So we went to the bosses and said, do you want to have that? You don't want your employees to think that they can't, that they have to pick up the phone. So here's an example of, there we go.
A day in the life. This is where I talk about with you guys what I've seen out there on the highway. Southbound 15, south of Mira Mesa, I look to my right and there's a young 19-year-old kid in his white Honda Civic. I follow him for 3 miles until we get to Miramar Way. When we get to Miramar Way, he looks left, we make eye contact, and we have what I like to call true ejection, right? It looks like this. Right? And he chucks his phone. What did he forget? He did forget to turn it off, but what else? Forgot that his back window was down. So as he ejects his cell phone from his hand, I watch it come out of his hand, hit his rear seat, come out his left rear window. Over the right side of my patrol car, his cell phone slides across 5 lanes of the 15, right? And then Mr. Big Rig finishes it off, right? A little cell phone fatality out there. I took my little yellow blanket and I covered up the cell phone, right?
So then he goes on to say, so what kind of ticket did I give him? And somebody in the audience says, littering. And he says, you guys are really harsh. That ticket's $1,000. I gave him a $150 ticket. So that's just some snippets from what we do on distracted driving. And I know this group's going to say, well, how do you know you've changed behavior? So that's very difficult to measure. We're funded by California Office of Traffic Safety to do this public safety work. California Office of Traffic Safety isn't a research institution. They're like, go out and fix distracted driving. Go out and change the public's behaviors. So we've had to build our evaluation into pre and post testing. And then I'll show you one thing that we were able to do, but it has limitations. When the PIOs go out and they're not, people who work for me going out to do this, I have even less control over how to get back that evaluation. And certainly nobody signs up. We don't have a way of tracking people. I mean, ideally we'd administer it to the intervention and the control group, but that's not how OTS rolls. OTS is like, just go fix it. We don't want you testing some kind of intervention that you've done. So it has been somewhat frustrating to rely on pre and post testing. And when you ask somebody who just saw this, you know, how motivated are you to change your behavior? Yeah, I'm glad to see, you know, 89% of people said yes, but I'd be kind of shocked if at the end of post testing they didn't. So we did get some rather reassuring participant comments that I'm just showing you some snippets that, you know, people were happy with the intervention. One thing that was very reassuring to us is we asked for volunteers who were willing to give us their emails, and then we said we put them in a lottery for an iPad, and then we have a way on SurveyMonkey where we can not break their confidentiality in terms of the answers to their question, but their names can still be put into a lottery to be able to get prizes. And for those of you who are trying to collect data from people, it's a much cheaper way than paying people $10 or $20 per person to do this, and it seems to be very well received. Just an FYI for those of you who are doing this. So I was happy to see that people 3 months later said, I do less of these things. So less hands held and hands free. By the way, before we leave this topic, hands held and hands free are just as dangerous one to the other. If you're thinking that you're safer going home from this talk and you're not riding your bike and you're on Bluetooth, you're not safer. You're much safer than you are if you were texting. Obviously, if your eyes are off the road, you're very unsafe, but you're not better off than you would be holding it to your ear, crazily enough.
Linda, people have very short memories. So after they go through this, they may be impressed and then they will change for a while. But then maybe a few months they go. So have you thought about, you know, have people repeatedly, you know, doing this training for maybe for 2 years and see how that will?
So we did build in a kind of sustainability component in that we train PIOs every year. And the CHP has been, as I said, just an incredible partner. So in both north and south part of California, we hold workshops, the PIOs come. So we're continually finding, you know, as the PIOs turn over, able to train them. They're able to go out, back out to their communities as many times as an employer would want them to go. For some of these, and I'll get back to that, we have a little bit more of a captive audience and we're able to do some maintenance. So that's a really good segue. We are trying to change distracted driving in commercial drivers. So it's one thing to have a 3,000-pound weapon and you're driving blind because you're looking down at your phone. And it's another to have a 12,000-pound weapon going down the road and the driver's distracted. So the way that we've been able to reach out to commercial drivers is through more of their regulatory agencies who have given us access to the commercial drivers. So in that case, and we just got funded to do this nationally, in that case, we're definitely building in maintenance. So we're going out, we're doing kind of the initial, this is why we care, and then going back to them with reminders, little video clips, emails that we hope they're not looking at when they're driving, and so on. This is for just, again, to give you some examples, the goals of what we want the commercial drivers to know about, and talking to them about the increase in fatalities amongst commercial drivers. And then we try to include in all of our talks some kind of interaction with the audience. We, you know, allow true and false, and you know, what do you think the answer is to this? Why do you think people are behaving that way? We also try to incorporate a lot of videos.
The California Highway Patrol has commercial enforcement units on the road looking out for distracted commercial drivers.
Often when we make commercial vehicle stops for people that are distracted using their cell phones, talking or texting, they give excuses that, hey, my boss just called, I'm trying to find out where I'm going. And the bottom line is the call can wait. They can wait till they get where they're going or exit the freeway to a safe location. I think one of the most difficult things is when we go to vehicle collisions involving commercial motor vehicles, a lot of times they're preventable. People are a lot of times are distracted, they're not paying attention, and if they just been watching the road, the whole thing could have been avoided.
So again, I've got a number of curriculum to get through, so I'm just giving you some of the snippets and sort of give you the idea. Each of our audiences is slightly different. The commercial drivers obviously have a very different focus. You know, they're wanting to, you know, they drive for a living, they have different regulations and so on. So speaking of audiences, we also do pedestrian safety workshop. Now, as you may know, the pedestrian fatalities are concentrated in the youngest and the oldest populations in the United States. The youngsters are often covered by their schools. There's quite a bit of programs across the country in pedestrian safety for youngsters. So we focused on the older adults and used the same model. So training PIOs to go into senior centers, community centers, talking to older adults about what they can do to keep themselves from being a victim of a crash, talking to them about how pedestrian fatalities are increasing also. Now, I've shown this to you in order, you know, high amounts of distracted driving increase in pedestrian fatalities. I think there's a relationship.
We do it all the time, cross the street, usually without being hit by a car. But pedestrian vehicle collisions are an increasing problem, especially for older adults, nearly always leading to serious injury, even death. Fortunately, many of these injuries and fatalities are preventable by simply following basic traffic laws.
So you get the idea. We talk to people about, sorry about the correction. We talk to people about what they can do. I mean, there are really specific things that people can do that will reduce it. Something like 60–70% of pedestrian fatalities are people who aren't crossing at the light when the light's green and when there's enough time to cross.
We did a data collection last year for new pedestrian signal, and at some of the sites we found a lot of the pedestrian violate the signal. Basically, they walk when it's not supposed to.
Yeah, I do some pro bono work for the city of New York only because I really like theater, and I'll go to New York any excuse to go to theater. So I've been working with them for about 6 years. And the jaywalking in New York is just completely out of control. And their senior population is again also, you know, highly overrepresented in the pedestrian fatalities. So that's something they really care about. So we also have a program for older adults on safe driving. And again, the PIOs go out, wherever older adults, older drivers are hanging out, finding them, you know, advertising, getting people to come to the seminars. So we created the curriculum for them, talking about these topics. One of the topics that you haven't seen before is kind of self-assessment. So it's estimated that if we live long enough, your average woman will outlive their driving by 10 years and the average man by 6 years, just because men have a shorter life expectancy. So at some point, we hope older adults will have the opportunity to experience driving retirement. So one of the things that we want to give the message is, like, how do you self-regulate, and what are the things that you're going to look for that your driving is deteriorating. We just did a study in the simulator showing that how reflexes decrease with age, and also how being able to identify objects in the periphery, especially during distraction, deteriorate with age. Not that anybody does it well. One of the things that we suggest to the older adults, just again, I'm just giving you snippets of the curriculum, is that they make more right turns than left turns. So interestingly, in our study, in our AAA study of the 3,000 older drivers across the country that we recruited to our AAA study, we looked at which medications were associated with these driving behaviors. And what we found is CNS drugs that cause, so your CNS drugs are like your painkillers, including opiates. Those were associated with speeding. And antihistamines were associated with people making more right turns than left turns. The ratio changed. So we're thinking, well, maybe people are feeling a little ditzy from their antihistamine. They're a little insecure, so they're going to make more right turns than left turns.
Timing is everything. And when you're on the highway, every second counts.
We did not make
We usually think of stopping in terms of space, but what really matters is time. It takes about 1.5 seconds to notice a potential risk in front of you, and another 1.5 seconds to react, hit the brakes, and slow down. So you want to give yourself at least 3 seconds between the car in front of you and your vehicle. To measure, wait for the car ahead of you to pass a set object. Tree, road sign, light pole, any clear marker will do. After it passes, start counting. 1001, 1002, 1003.
You get the idea. I'm just, sometimes we find really good videos that somebody else has made, and then if we don't find them, then we make our own. I would say we make our own about 4/5. Yeah.
I'm curious how your participants, and especially in that study, respond to kind of the notion of losing independence and how scary. Like I'm having this issue within my own family, you know, and it's like, no, and how the hell am I going to get anywhere if I can't drive myself?
Yeah.
But like, how do those conversations go, and what are you guys talking about?
So I've never given a talk on older driver safety without somebody raising their hand and saying that they're facing this in their own family. It's so common, and it's very difficult for people to not drive in this country. Before the talk, we were having lunch and talking about the problems of the inadequate public transportation in this country, and really that gets to the heart of it in terms of what do people do for giving up driving. So what we do is we talk to them about what are the disadvantages to driving. So you have your issues around liability. Do you know, have you guys seen the study? How much does AAA estimate that it costs to operate a car every year?
The statistic I saw is spend on cars like $5,000 to $6,000.
So AAA says 9,000. Maybe how much they're including, like, you in addition to the car, the depreciation, the car insurance, the gas, the parking, and the concerns about liability. So we've been trying to put a positive spin on it. Definitely, it's a very emotional issue. It was so emotional that you knocked your water over.
I can handle
it. It's just like, I really feel for you.
I have a follow-up question.
Yeah.
So, have you talked at all with some of your older participants or people that you're speaking with about these vehicles with semi-autonomous capabilities, like adaptive cruise control and lane correction and stuff like that? And do you know if that makes them a more qualified driver than they would be on their own?
So actually, the group that's been studying, we're collecting all that data in our AAA study, and we have all the data on what equipment this group of 3,000 older adults has, and what are they using. It's the insurance. There's an umbrella insurance watchdog, not watchdog. that does research on this kind of thing. I often sit on a panel with them, and they have been collecting this very carefully and have been showing that those have reduced crashes, that those kinds of things, the lane warnings, all the bells and whistles, the front stop, but have been very helpful. So as people's cars turn over and they acquire these things, that is useful. You still got the problem with the older driver that you've got a decrease in vision where over the age of 80, 25% of people have severe vision impairment that can't be corrected. You have cognitive decline with 30 to 50% of people over the age of 85 having significant cognitive decline. And then you've got general frailty, medications, and other comorbidities. That's just the reality. It's not ageism, it's just the reality of what we're dealing with. So I'll show you very quickly what we're doing with teens. We have also been partnering with a local police in going out to schools and boys and girls clubs and other places where teens hang out and talking to them about alcohol and underage drinking and driving. So we've incorporated
Blood alcohol content,
cannabis
BAC,
as well, but
is the
most of
amount
the
of
focus is
alcohol in
alcohol.
your system. If you are over 21, 0.08% BAC is illegal. Under 21, 0.01% is illegal. Here's the thing, one drink, just one drink could get you to that point. California has a zero tolerance law. If you are stopped and test at 0.01%, it can lead to a citation and additional consequences, including having your license suspended.
So you see, we kind of hopefully changed the content of our videos to sort of match our audience. We've also paired the work that we're doing with teen alcohol with having law enforcement has a program where they'll take teens out to see DUI check stops. For those who can't go out and see them, we created a video.
So what happens at a checkpoint? It all depends on what officers see, smell, and hear. First, they ask a couple of questions. Check out how your breath smells, and take a look at your eyes using a test called the horizontal gaze nystagmus test.
All right, watch my thing with your eyes only. Keep your head still, don't move your hip.
Even if you think you're cool under pressure, or that breath mints will mask the smell of a beer, you can't control what happens to your eyes when you are impaired.
It goes on. So we talked to them about cannabis as well, and how, if people with the legalization of cannabis, that there has been an uptake. Actually, the fastest group, but not the group with the most users, is the people, the baby boomers who were smoking when they were young, and then now that it's legal are interested in smoking again. So again, all of these, I'm just giving you snippets. All of our curriculum lasts about 45 or 50 minutes with room for questions, and then we end this one with
Look like Justin Trudeau or Bill Clinton.
Hi. A taxi. Friends do whatever it takes.
we didn't write that one, but we really like it. So with the legalization of cannabis, we thought we better go out and talk to the adults about cannabis and driving. So this is our most recent curriculum. We just finished it and did our pilot studies in the fall, and now this is rolling out. Now we're training the PIOs. So included in this is the increase in THC concentration from 2001, just a massive increase. Also, we talk a lot about the effects of cannabis and how long it lasts apropos to driving. So with inhaling, because of the rapid intake through the lungs, it gets in faster, it gets out faster. But with the edibles being a problem, and as you've probably heard, one of the things about edibles is that because people don't feel high fast enough, sometimes they eat too much, and then they have a delayed effect. So that can really affect, 8 to 10 hours is a long time to not be driving after cannabis use. So we have a lot of discussions about that in the curriculum that we have. One of the researchers that I work with at UCSD, Tom Marcotte, has a grant from California Highway Patrol and their cannabis research center at UCSD, where they were given IRB permission to bring people who already use cannabis into their lab, roll them a joint, and then start collecting breath, saliva, blood, and urine from them every 30 to 60 minutes and putting them in a simulator. And one of the things that he's found is that there was a delay in when people realized that they were no longer, I'm not saying this properly. So every hour they would ask people, do you think you're ready to drive? Do you think you're ready to drive every hour? And what they found is that the impairment went on for 4 hours, but after 3 hours, the subjects thought, I'm ready to drive. But yet they could still demonstrate impairment in the simulator. So that's a...
Wouldn't that just be based on a person's tolerance to the drug? And instead of like some people could be consuming cannabis every day and it wouldn't do anything to them, but then someone that consumes it once a week could be impacted more and they might have to wait longer like that. So when
that's true.
Be like a wider
That's true, but in this case, they were showing that people were still impaired till 4 hours. Mm-hmm. But the same people were saying, I'm ready to drive at 3 hours, but they showed they weren't ready to drive it until 4 hours. So it's true that you have a situation where some people are using cannabis and they're, using it in a way that there's some habituation. But in this particular example, these were people who were still demonstrating impairment in the simulator.
Yeah, feeling okay to drive is like the most subjective thing.
For sure, but people make those decisions all the time. You go to a bar, you go to, in my case, you go to a dinner party and somebody serves, wine, and then you're saying, I'm okay to drive. You're always making that decision. So the question is, how accurate is that decision?
Well, that's what drugs do, is they make you feel like you want to do stuff that you probably shouldn't do.
Right. So our message to people is, we have lots of options now. Well, I think I'm jumping ahead. I think I've got that.
Smoke and drink a little and be fine to drive.
No, you can't.
I actually drive better when I'm high.
Well, you can't tell that I'm driving high.
Yeah, we can.
So we made that as a PSA. But we also have a longer version that we show in the video. And then we talk to people about what their options are. And we tell people, make your transportation plans before you leave, whether it's alcohol or cannabis. Why not plan ahead? One thing about a designated driver is sometimes when people have been asked in the group who's the designated driver and what makes them the designated driver, the answer sometimes is that's the person who's had the least to drink, whereas really it should be the person who's had nothing to drink. So we talk about that. So of our, let me just stop there. That's actually much higher than that. So when you say, how many people have we been able to reach with our intervention? So with distracted driving alone, with distracted driving with the Just Drive, when we had control of it before we even gave it to the PIOs, we were over 10,000 people that we've been able to reach. And now the PIOs are going across California with the curriculum. But we know that it's a really labor-intensive way of reaching people, and it's not like the best way to reach 40 million people. So we've also used social marketing, which draws on, you know, advertising, other kinds of marketing. Social media is one aspect of social marketing, but we, like that particular clip that I just showed you, can turn into a PSA that could be standalone, and we've done that with a little bit of additional stuff.
Weed, pot, kush, dank. No matter what you call it, it's illegal to drive high. Driving high is a DUI. Brought to you by the TREDS Higher Education Project at UC San Diego. If you do, don't. It's illegal to drive high. Driving high is a DUI. Brought to you by the TREDS Higher Education Project at UC San Diego.
Example. All right.
Whether you smoke it.
Oh, we got the idea. So we also made cannabis fact cards. So we encouraged our law enforcement partners that one of the things that they could do besides giving citations and arresting people is educate people on the street. So we created like fact cards for them to try to tell people how long people may be impaired. And we also do work with physicians, and I'm going to talk to you about that. I still have some time, and I wanted to talk to you about our professional training as well. Physicians are a really difficult group to get to do things because, well, you know, I've been doing patient care for a long time. You're just under a lot of pressure to keep going. We've got about 15 minutes to get all of our messages across and take care of people's concerns and order lab and prescribe drugs. It's just a very hectic environment. So when I try to get physicians to actually do what I want them to do, which is to be behavior change agents in the area of injury prevention, it takes a lot of convincing. And you have to make things very simple for them. So we created pocket guides where you can just say to people, look, if you're going to smoke cannabis, these are the things you should worry about. If you're going to drink, you know, don't try that. Try to make their talking points for them very easy. As you can imagine, with social marketing, this again, outdated. It's been very easy to reach people on Facebook, on YouTube. CHP has posted our videos on their website. That has been like a way of reaching people, but we don't have any way of knowing really how well we're doing at changing behavior. And these are very short little snippets, some of them. It's been difficult. So as I said, we also do professional education because we view this as a way of also changing behavior. So first, I'm going to tell you about what we developed for older drivers. So say, why do you need to train law enforcement on older drivers? Well, we did focus groups with law enforcement, and it turns out that law enforcement said to us, we really hate the older drivers stuff. You've got, you know, an 85-year-old driving the wrong way on a residential street, and that stop's going to take hours. And meanwhile, there's like, you know, the cops would say there's all these young people who are speeding or they're driving impaired, and we'd rather be dealing with them. And so what they were telling us is that they were being very lenient with the older drivers, and they were not reporting them to the DMV. So the mechanism for law enforcement to help the older drivers, first of all, if they're impaired right now, if I have somebody in front of me who doesn't know who they are, where they are, or what time it is, that's somebody who shouldn't be driving right now. So that person should be off the road now. The question about how long they should be off the road isn't. my decision as a mandated reporter, and it's not law enforcement's decision, that's DMV. But DMV doesn't know there's a problem unless you tell them. So after having focus groups with law enforcement and figuring out, how much of a problem do we have, we created a curriculum for law enforcement to show them that this is a problem and this is what you should do.
Police say an 86-year-old man behind the wheel of a fast-moving 1992 Buick he claims he couldn't stop plows through 3.5 blocks of a crowded street closed to traffic.
What's the next thing to remember? Something hit my windshield and just shattered it. When that happened, I couldn't see out anymore.
Okay, and you know what it was that hit your windshield?
No
idea. So one of the things that we did to try to help the officers is we created a tool for them to keep in their ticket book. And the tool was this concept of orientation to person, place, and time. We've been using this in medicine a lot. So the term disoriented, it's not the same as dementia. Dementia is a diagnosis, it's a progressive neurological disease that causes cognitive impairment. Disorientation means right now I am so confused, I don't know where I am or who I am or whatever. Often people who are disoriented also have dementia, but we created a tool for officers. They're not trying to diagnose, they just need to know, is somebody confused right now? So we created a tool for them that we call the DOSI, and we also developed it for their cell phones so that they could just download this for free. We made this available as freeware, and any officer across the country can download this. And in fact, Quebec's made this into law. They heard, I met them at a conference, they heard about this, and they have incorporated the DOSI into law. So as I said, it asks about, who you are, where you are, what state you're in. You might ask the question, well, what if you're drunk? Are you going to be disoriented when you're drunk? So the way we tested that is the way law enforcement trains officers to do roadside testing is they get a bunch of volunteers to come to the DoubleTree Hotel or wherever, and they systematically get them intoxicated. And then the officers get a chance to test people, and they keep doing breath tests. Okay, here's a bunch of people who are 0.08, and here's a bunch of people who are 0.16. See if you can tell the difference, and so on. So we're like, hey, could we come in and administer the DOSI to people as they're getting intoxicated? It turns out you can be really drunk and you still know your name, your date of birth, where you live. So we were quite sure that the officers were not going to confuse disorientation and intoxication. And then just to be sure that we had this right, we went to our Alzheimer's center where they have a lot of volunteer controls, older volunteer controls. And we were able to show that on average, people who are have dementia missed 2.5 of our questions. So then we train officers on who should be reported to the DMV. Again, as a physician, as an officer, we don't take away licenses. We only let the DMV know to evaluate people further.
But that's all part of growing old. But what does that have to do with my driving anyway?
Based on my observations of your driving, you pulled out in front of another car. You're swerving all over your lane. I just think that it's in the safest interest of everybody else and yourself that you don't continue to drive today, okay? Is there anybody that you know that we could call, maybe come pick you up?
No, I'm perfectly fine. I've been driving longer than you've been alive.
Sir, I understand.
So that's yes.
I understand doctors are very reluctant due to the patient-client relationship to report their clients.
That's a wonderful segue to my last curriculum that I'm going to show you. Thank you. That was a snip from a 9-minute video that we created. That's like the ideal traffic stop. Shows the officer, who's a real officer, using the DOSI with an actor, and then, you know, taking him off the road. So, funny story. I'm in New York, as I said, I do pro bono work, and NYPD asked me to come present the older driver traffic stop to NYPD. I'm like, okay. And they take me out to their training center, and I'm at the podium, and then 200 armed men in blue show up in the audience, and I'm like, really? So I go through my talk and I show this video, and they're doubled over laughing. And I'm like, okay, why? They're like, California Highway Patrol, we're not that polite. So we have trained every single California Highway Patrol officer in the state on older driver safety. And then, I lied, actually, I have 2 more things to show you. So we also asked them, how about if we help officers not distract drive? We think it's a problem for officers too. And they said yes. We told them that when their PIOs are going out and talking to the public, often somebody in the audience will raise their hand and say, hey, I see officers on their phone. So they were like, yeah, we want your help. So we created a Just Drive like curriculum, but targeting officers for officers to try to improve their safety. And we talked to them about similar things, but all the pictures are police cars, and you know, we have testimony from
and I'm going over
officers.
an overpass, and a buddy of mine has sent me a text on where to meet for lunch. So I have the phone in my right hand, and I'm looking down at my phone, and as soon as I look up, I'm doing about 35 miles per hour, and I see the traffic is stopped ahead of me. What was funny is I looked in the side view mirror of the car that I was approaching, and I could see the lady gripping her steering wheel, like bracing for the impact, because she saw the patrol car coming at her, you know, pretty fast. So I hit the brakes and was just able to stop about a foot off of her bumper. And as I stopped, I looked at her, she looked at me, we both took a deep breath, waved, and that was it. So I was this close, because I was looking at my cell phone, from hitting that car.
So you get the idea. Better that the testimony come from another officer. So throughout this, I haven't bombarded you with a lot of evaluation. Again, every time we do this, we do pre and post testing. We're trying to build in, especially in higher education, the same kind of concept. Give us your email. We'll send you an email. Your answers will be anonymous. We'll enroll you in a lottery. We're trying to do that as much as possible. Certainly, the officers were harder to convince that they were not safe driving while they're using cell phones. I mean, still disappointingly low results, but they did say that their awareness and they intended to change some of their cell phone behavior went up, and you know, a lot of nice comments. So the last thing I'm going to show you is what we tried to do to get to the answer to your question is, how do we talk to doctors? So we created a curriculum for doctors talking about, this is what, by the way, I think it's kind of interesting. This is what the world looks like to somebody with macular degeneration. The middle part of their vision goes away, and eventually it's just completely gone. You can see how driving with macular degeneration would be a problem. This is cataracts that are untreated, leading cause of blindness in the world, but you know, completely reversible, and glaucoma. Glaucoma, you can see it causes peripheral vision problems, but the central vision is spared. So we remind doctors of that, and then again, I'm just giving you the snippets. The American Medical Association, the National Highway Traffic Safety Administration, the American Geriatric Society all got together and said, what are the tests that we can do for older adults that best predict who shouldn't be driving. We talk to them about what medications are bad. I mean, doctors are prescribing the medicine. They should know what the effects of those medications are on driving. And then one way to get to physicians is to talk to them about risk management and their liability. So I point out, which many physicians don't know, is that dementia is a reportable disease. All lapses of consciousness are a reportable disease. So as a physician in California, of course I have to report TB, coronavirus, measles, of course I have to report all those things. What most doctors don't realize is lapses of consciousness is on that list, and if you don't report, then you're liable. So what's happened in California on a number of occasions is the physician has not reported, their patient has gotten in a crash, and then the victim's family or the victim, if they survive it, sues the physician. So I get physicians' attention that way. It's one way of approaching it. Across the United States, there's a huge variety of ways of reporting. So California is a mandated reporting state, but only 6 other states are. And the other states are either permissive or there's no mechanism for reporting. There's no way that I, as a physician, could tell the DMV that I had a patient with a brain tumor who was, losing consciousness. So the other way that we've been able to reach docs is through the medical board. So this is who licenses physicians, physician assistants, and podiatrists. So every quarter we get this in the mail. And the first thing doctors do is they open it up and they look to see who got recommended, because it's got a list of all the doctors who are recommended. So this newsletter really gets people's attention. So what we've done is we've convinced them that if we'll write 300-400 word essays on the physician's role in driving safety. And we know it reaches 160,000 practitioners in the state. So really cool way of reaching people.
Older adults and their families depend on us to identify risk factors that
We also
impact
created
driving
videos
and assist with the transition into driving retirement.
So again, trying to make it easy for the docs. All they have to do is go to our website, and the training that I provide in person, they can get online. Again, just like with the cops, we tried to model the ideal office visit, telling the patient that in this case, this patient was just diagnosed with dementia, and talking to them about what language they can use so that their patients aren't worried, feel supported, know the reasons that you're reporting them. That has been a really awesome way of reaching physicians between the newsletters and so on. And we've had, some good results with physicians saying that they often didn't know about this reporting. And then we did the same 3-month thing. And this is just one example. My counseling has gone up. So that's the end of my talk. Open a question. Yeah, we'll open up to questions. It's late. Yeah.
So speaking of the distracted driving, so using cell phone hands-free or either hands-free or handheld cell phone is significantly affecting their driving practice. But recently, so car manufacturers are trying to get those drivers more distracted with bigger display or Bluetooth hands-free connection. Yeah. Yes. How to think about that? what you can do for car manufacturers or navigation systems?
No, it's completely ridiculous.
Yeah.
And there's something about talking to somebody else. So if you have the person sitting next to you, it seems that that's a kind of shared experience. You both see what's going on. The person's merging the person stops talking, or in my husband's case, he's a much better driver when I'm telling him what to do. Slow down, watch out. When you're talking on the phone, there's no shared experience. And the person who's driving is like beholden to the person on the other end of the phone. And you guys all know this. I mean, you know, you're in a restaurant and you're talking to the person you're with, and then the person at the next table gets on the phone and they're like so clued out, they don't know how loud they're talking. They're saying things like, "Are you kidding? You're saying that out loud right next to me." So I think it's a really bad idea and getting drivers, anytime the driver takes their eyes off the road, they're driving blind. I mean, it's just crazy.
For a while, I would see a truck driver holding something and talking on it, and I'd call the company and report it. And then somebody said, "Oh, it's a radio. It's not a cell phone, it's a radio."
That they're holding to their ear?
Yeah.
Oh, okay. Well, so it seems that generally music's not a problem. It's the interaction that's the problem. Different topic?
Yeah.
Okay.
I do know truck drivers communicate with stress stops and time and stuff like that. So they definitely have the radios. I think that's the
right.
Oh, discussions.
Yeah, they definitely need.
There's not a lot of music just sitting around.
Oh, there's not. So it's more of a CD?
It's like you talk to other truckers.
Yeah. You know, anytime it's interactive, it's going to be a problem.
I think they're pre-installed in the trucks and everything.
Yeah. No, it's what can I tell you? Yeah.
Is there anything that people have done to change the design of phones so that they can't be used?
So certainly, definitely, the phone companies could take care of this tomorrow. They can just say if the phone's going more than 10 miles an hour, that the phone will be disabled. They could completely solve this problem. And you know, people will say, "Well, I'm a passenger," and they're just going to press the "I'm not driving." You know, that exists too. If my husband's driving and I try to make a call or a call is coming in, my phone will block it unless I tell it I'm not driving. I mean, people will get around it, but they could drastically reduce the amount of distracted driving if they wanted the technologies there. They've just chosen not to. And in fact, AT&T has done a massive campaign, It Can Wait, and it's only focused on texting. They've made the decision that they're not going to address cell phone use, just texting.
So Linda, there are a lot of people put their cell phones as a navigation device and put on the car. And would that have some effects on the distraction or?
So I think if you take your eyes off the road, your eyes are off the road. So if you're having to look away a lot to look at and distract that navigation device, that's a problem. If the navigation device is talking to you, that's fine. And it's not like a cell phone. Again, if you're not having to respond, your brain doesn't incorporate the language part of your brain like that. So I think, especially the ones that talk, that's fine. What we say is, plan your route ahead of time and look at your GPS ahead of time and then put it there and try to get it to talk to you. 1, 2.
Okay. I'm curious about the use of law enforcement. And you mentioned in the beginning of your talk that you usually work with communities that are impacted seemingly by law enforcement in the areas, migrant communities and undocumented folks. And from my experience studying Vision Zero and people's resistance to that extra enforcement piece because of the negative effects it has on more vulnerable communities and the amount of trust that we can have with law enforcement, I'm thinking a lot about like how effective is using CHP PIOs versus and like do you have plans to use other folks?
We do, and we do use other folks. We invite anybody to come to our trainings. Mm-hmm. So the problem has been who's who's got the time and who's paid to do it. So we're not paid to do it. We're only paid to develop curriculum. But other groups do come to our trainings and do go out into the community. I think when law enforcement is acting in an educational role, maybe they're better received. I think CHP is better received than local law enforcement. I totally know what you're saying. It's the other reason that we use social marketing is so that we have alternatives in terms of reaching people. Sorry, and your question?
I feel like there is a greater dichotomy between talk the talk and walk the walk. So even after this seminar, getting distracted or using phone on the car is really bad. But once you go out of this room and start writing, I'm sure still is powerful. So is there a mechanism to reduce the gap between the talk and walk the walk?
Yeah, that's it, right? We've got to. It's the total challenge in public health is that how do you go from knowledge to behavior change? That is the whole thing that we try to work on, knowing that starting out with knowledge change is part of it, but trying to move people into motivation, that's the big thing that you have to do. And so thinking about how you can get your message across that's as motivating as possible.
I mean, so far the motivation is all about cost, whether it's a fine, cost of life, or but is there a mechanism beside the cost that can motivate people to sort of use these things, or to reduce the gap between talk the talk and walk the walk?
Did you have an answer?
Well, I was just gonna say, I feel like it's kind of tough because what I think works the best would be when people feel shamed to do something. I feel like that's a really good deterrent from getting them to do that. But as a public health professional, you shouldn't really be shaming people because you also want to be an outlet for them to speak to and communicate with about these things that they have going on. But I mean, that's what I kind of struggle with when I think about this is I feel like shame is a really good way to deter people, but it's also not appropriate to shame.
There's behavioral economic studies that there's a case with the kindergartens. Parents are always late, and initially they fine them like $5 and $10, and the parents just keep the money. But they later on they shame the people who are late and don't need to pay the money, and actually that reduced significant amount of the late. So that's a case that for your shame the.
Yeah, I mean, I think we have to look at the lessons that we have done where we've had public health successes. So, smoking has been a public health success, and again, as I said at the beginning, part of the way that we got people to change their behavior was by having them look at how it affected the people in their lives. I didn't have time to go into all of the manipulation that we do during our talks, but one thing we ask people to do is to do a pledge card and to write down one thing, who they're doing it for, and what one thing they could do to reduce their distracted driving. Again, trying to play on connect, who are your connections, who would care. Just like people are using kids to get to their parent smokers and that kind of thing. I mean, we have had some. I will say that I'm all about education, and I'm all about the individual changing their behavior. I think there is a role for enforcement. I think if you were to stop highway patrol from stopping any speeders on Highway 80, that people would be driving faster. I mean, it's really sad, right? And it seems to be that enforcement has a role in public health. And look at what happened with smoking. I did a sabbatical in England where smoking was still allowed in the hospitals. Oh God. And you're talking to the surgeons and they're saying, you expect me to get through a surgery and I haven't had a cigarette all day? Like, really? Yeah. And then, you know, then they finally came in and they said, you know, there's not going to be any smoking in public places. No more pubs. The pubs aren't smoking. Like, you can talk until you're blue in the face, and then sometimes legislation comes in and they change your behavior. And look at California, less than 10%. UCSD, probably UCS Davis too, completely smoke-free campus. You know, imagine that.
Now all the cigarettes are on the street across from campus.
But it's gotta be a deterrent.
I think we'll stop here, and Linda can stay
I'd
for
be happy
a few minutes to talk to you. Yeah.